Hello everyone, welcome back to the PolYneer podcast. The show where we dive into the latest advancements in medical science. I'm your host, Vivian. And today, we have a special guest joining us from the Chinese University of Hong Kong, Dr. Molly Lee from the Department of Clinical Oncology. In this episode, we will be talking about drug delivery systems for non-small cell lung carcinoma, or NSCLC, and discussing the challenges, innovations, and the future of lung cancer treatment. Dr. Lee is currently the principal investigator of more than 15 lung cancer clinical trials, and he is also the principal investigator of a number of translational studies and preclinical studies testing novel drug combinations in cell lines and patient-derived xenograft models. Today, he will be sharing his expertise on lung cancer and giving us further insight on the drug delivery system. Before we dive into our questions for Dr. Lee, let's briefly discuss drug delivery systems for NSCLC, as well as their effectiveness and limitations. The primary goal of drug delivery system is to maximize the therapeutic effects of a drug while minimizing its side effects. For NSCLC, there are several drug delivery systems, including oral and intravenous administration, targeted therapies, and immunotherapies. Each of these has its own advantages and disadvantages. And the choice of the treatment depends on factors such as the stage of the cancer, the patient's overall health, and the molecular characteristics of the tumor. So now, let's move on to the conversation between Tiffany and Dr. Lee.
Thank you, Dr. Lee, for being our guest. Will you please introduce yourself?
Hi, everyone. So I'm Dr. Molly Lee from the Clinical Oncology Department of the Chinese University of Hong Kong. My research interest is mainly in lung cancer, and I currently run a number of clinical trials as well as preclinical studies in CHK. So thank you for inviting me for the interview, and I hope I can answer some of the questions that you may have.
Thank you, Dr. Lee. Thank you so much. Maybe first we might ask, you have faced many different cases, right? And what is the biggest challenge in diagnosis and treating lung cancer?
Okay, so for lung cancer, we know that it is the most lethal cancer actually globally as well as in Hong Kong, with the highest cancer-specific mortality and the highest mortality in total. I think there are two major challenges in the lung cancer management. First is that more than 50% of patients with lung cancer actually present with stage 4 disease, which means that the cancer has already spread around the body and has already developed metastasis, and they are no longer curable. Second is that even though we now have many more modalities of treatment for these patients, treatment resistance is still a major problem. And even if we have targeted therapy and immunotherapies, these novel treatments available, the 5-year survival still remains poor, and it's only around 10 to 30% for most of these stage 4 lung cancer patients.
Wow, we were totally unaware of such information. Thanks for letting us know about it. Moving on to the next question. Since lung cancer is a global health issue and current treatment may lead to treatment-related resistance, many countries are conducting research in finding new ways to overcome this hurdle. Could you share with us some experience where an innovative treatment has significantly improved a patient's outcome? What new advancements have you found particularly promising?
Right. This is an excellent question. I would like to share with you about the story of EGFR. So EGFR is actually the most common driver mutation and oncogene in Asian patients with non-small cell lung cancer. And actually more than 50% of non-small cell lung cancer actually harbor this EGFR mutation in East Asia, which means that this is our population. Also, it is also correlated with younger age of onset as well as a non-smoking status. in the past, well before 2000, where we don't have targeted therapies for these patients, the treatment would consist of chemotherapy mainly, which is quite toxic. It requires intravenous injection, and the treatment response is usually poor. Actually, most patients have a median survival of only around 1 year for these patients. And with the discovery of EGFR mutation as well as targeted therapy, the survival outcome has markedly improved. Nowadays, for patients with a stage 4 metastatic lung cancer with an EGFR mutation, the median or overall survival has extended from the historical rate of 1 year to more than 3 years right now. Also, we have these targeted therapies available, which is also associated with a low toxicity profile. They can be taken as a daily oral pill instead of an intravenous treatment. They also have a high brain penetration because these patients have a high propensity of developing brain metastasis, and such treatment actually can prevent and also reduce the brain metastasis as well. So all in all, it has also, apart from extending the survival, it has also improved patients' quality of life as well.
But this is still a serious problem, right? How do you see the landscape of lung cancer treatment evolving over the next decade? Are there any emerging trends or breakthroughs that you are particularly excited about?
Yes, so as I said, for patients with, let's say with EGFR mutation and treated with TKI, targeted therapy, although the survival has markedly extended to 3 years with a relatively good quality of life, treatment resistance is still an issue. So eventually, most patients, if not all patients, will develop treatment resistance and die of this disease still. Nowadays, we have multiple new emerging treatment modalities that is under the clinical development for these patients. For example, for patients who failed the third generation targeted therapy, we may hunt for other new resistance mutation and use a novel targeted therapy combination for these patients. We may use the new treatments called antibody-drug conjugates, as well as bispecific antibodies. Thanks to the help of new computational designs and also bioinformatics in analyzing the different resistance mechanism for these patients. And similarly, in the immunotherapy setting, although we know that immunotherapy is what we call a magic drug, still, I think more than 80 to 90% of patients will eventually develop resistance, and also immunotherapy is generally not effective in patients with driver mutations. And nowadays, we also have a better understanding of the resistant profile of immunotherapy, and a number of these molecules are in development, hopefully to overcome the resistance to immunotherapy or to enhance the efficacy of such treatments. So I would say, all in all, the future in lung cancer treatment is quite promising.
Thank you so much for sharing your valuable insight on lung cancer and explaining the drug delivery methods. And speaking of drug deliveries and immunotherapy in cancer, can you tell us how you assess the effectiveness of immunotherapies for lung cancer, and what are the limitations?
Okay, so I guess we can divide this into two parts. First is that how can we predict the efficacy of immunotherapy? For immunotherapy, we are generally referring to immune checkpoint inhibitors. This is because that our immune system is usually dysfunctional, such that they cannot kill off cancer cells, and then cancer cells will grow in our body. Immune checkpoint inhibitors serve as a function to reinvigorate our immune system, such that our immune cells can recognize these cancer cells and kill them off. To predict the efficacy, nowadays in lung cancer, the mostly used biomarker is the PD-L1 expression. However, it's still not the best biomarker. So, for example, for patients with negative PD-L1 expression, immunotherapies, the PD-L1 antibody still works in around 10% of patients. And even if the PD-L1 is high, which means that 50% or above, immunotherapy only works in around 40 to 50% of patients. So a lot has to be done in identifying who will actually benefit or not benefit from the drug. And there are actually a lot of other technologies in development. For example, in predicting the patient's what we call HLA status, genetic status, performing using DNA and RNA sequencing, as well as using AI technology to predict the immunotherapy response. Regarding the treatment response, after we have started treatment, generally speaking, the assessment of the treatment response is similar to what we do with the other treatment efficacy. So we follow the patient's clinical status, as well as perform serial imaging scans to look for the tumor response. Of course, there are also some other also new platforms in development, for example, plasma, DNA, or blood taking to look at the treatment efficacy.
Thank you so much, Dr. Lee, for sharing your expertise and insight with us.
Okay, thank you for the interview. So I hope that I have answered some of your questions. And
all right, everyone, we have come almost to the end of the podcast. To wrap up the conversation with Dr. Lee, let's quickly summarize the key points we covered today. During the conversation, Tiffany and Dr. Lee discussed the challenges in diagnosing and treating NSCLC, the factors considered when creating the treatment plan, and also some innovative treatments that have significantly improved patient outcomes. And then, they also talked about the evolving landscape of lung cancer treatment and the role of immunotherapies, as well as the importance of patient participation in clinical trials. At the end, it's been a great pleasure having Dr. Lee on our PolYneer podcast. And for our listeners, thank you for tuning in. We hope you all enjoy this episode, and we look forward to bringing you more exciting conversations on the PolYneer podcast.